Prediction rule. In this case, the modified Wells score for pulmonary embolism, which would give a score of 3, low probability, answering yes only to the criterion PE, is the number one diagnosis, and alternative is less likely. Interpreting test results. Imagine the patient went on to have a normal chest X-ray and blood results. Apart from a raised D dimer of 900, normal range is below 500 nanogram per ml. A normal chest X-ray is a common finding in pulmonary embolism. Several studies have shown that the D dimer assay has at least 95% sensitivity in acute pulmonary embolism, but it has a low specificity. A very sensitive test will detect most disease but generate abnormal findings in healthy people. On the other hand, a negative result virtually but not completely excludes the disease. It is important that it is important at this point to realize that a raised D dimer result does not mean that this patient has a pulmonary embolism. It just means that we have not been able to exclude it. Since pulmonary embolism is a potentially fatal condition, we need to rule out the worst case scenarios, ROWS. And the next step is therefore to arrange further imaging. What kind of imaging depends on individual patient characteristics and what is available. Treatment threshold. The treatment threshold combines factors such as the risks of the test and the risks versus benefits of treatment. A CT pulmonary angiogram (CTPA) could also be requested for this patient, although in some circumstances, ventilation, perfusion, single photon emission computed tomography V/QS PECT, page number 547, may be a more suitable alternative. However, what if the scan cannot be performed until the next day because pulmonary embolism is potentially fatal and the risks of treatment in this case are low? The patient should be started on treatment while awaiting the scan. Post-test probability. The patient's scan result is subsequently reported as no pulmonary embolism. Combined with the low pretest probability, this scan result reliably excludes pulmonary embolism. Cognitive biases. Imagine during this case that the patient had been handed over to you as nothing wrong, probably a pulled muscle. Cognitive biases, subconscious tendencies to respond in a certain way, would come into play, such as the framing effect, confirmation bias, and search satisfies seeing. The normal clinical examination might confirm the diagnosis of musculoskeletal pain in your mind, despite the examination being entirely consistent with pulmonary embolism and despite the lack of history and examination findings. Example, chest wall tenderness to support the diagnosis of musculoskeletal pain. Human factors. Imagine that after you have seen the patient, a colleague hands you some blood forms and asks you what test you would like to request on this lady. You request blood tests including a D dimer on the wrong patient. Luckily, this error is intercepted. Shared decision making. The diagnosis of pulmonary embolism can be difficult. Clinical prediction rules. Example, modified Wells score guidelines. Example from the US National Institute for Health and Care Excellence or NICE, and decision aids. Example, simplified pulmonary embolism severity index or PESI are frequently used in combination with the doctor's opinion derived from information gathered in the history and physical examination. The patient is treated according to evidence based guidelines that apply to her particular situation. Tests alone do not make a diagnosis, and at the end of this process, the patient is told that the combination of history examination and test results mean she is extremely unlikely to have a pulmonary embolism. Viral pleurisy is offered as an alternative diagnosis, and she is reassured that her symptoms are expected to settle over the coming days with analgesia. She is advised to re-present to hospital if her symptoms get worse. Answers to problems. Harvard problem, page number 5. Almost half of doctors surveyed said 95%, but they neglected to take prevalence into account. If 1,000 people are tested, there will be 51 positive results, 50 false positives, and 1 true positive. Assuming 100% sensitivity, the chance that a person found to have a positive result actually has the disease is therefore only 1 out of 51, or 2%. Bat and ball problem, page number 6. This puzzle is from the book Thinking Fast and Slow by Nobel laureate Daniel Kahneman. See further information. He writes, a number came to your mind. The number, of course, is 10p. The distinctive mark of this easy puzzle is that it evokes an answer that is intuitive, appealing, and wrong. Do the math and you will see. The correct answer is 5p. Further information, books and journal articles. These are the books and journal articles. And the websites. These are the websites.